We have Dr. Fabio Vannucci here for the last talk. Dr. Vannucci is our food animal pathologist, just like our other two speakers. So, watching the misbehaving Pasteurellas.
Assistant here from the sound guy. Thank you, Matt. The loud guy, yeah, I'm the loud guy too. So, well, thank you all thank you, Leman, for the introduction, and thank you all for coming and stick until the very last talk. Oh, that's great. Okay, of the section, and I just realized that Matt didn't show any histo slides, and Steph didn't show any histo slides, and I'm not showing any histo slides. That would be a record, having 3 pathologists not showing a single slide. But that's okay. That's okay. For today, what I would like to bring to discussion is not as the classical and what I would say old school that we know about the Pasteurella, because it's mostly, if you go back 40, 50, 30 years ago, or maybe more than that, you would remind that the Pasteurella would be the Pasteurella that cause atrophic rhinitis, that has a thermonecrotic toxin that you test for to see if it's severe or important or not. The Pasteurella that I would like to bring to discuss today is one that will be around that slide, all the discussion that I'm thinking in bringing, and hopefully we have questions by the end that we can discuss more. But basically, what I would like to add is that what is the difference, or how to interpret, or how can we interpret the Pasteurella that are isolated from cases like this, from cases like this, and from cases like this. So we do have the classical Pasteurellas that we all know. It's just old or young or old cousin of the Tripurella, which is there everywhere, and you just need to look harder to find the primary pathogen. But we are finding out that at least it's my perception here now, as we are having more and more farms that are becoming healthier, in a sense that the eradication protocols expanding, we are getting cases of Pasteurella that is misbehaving or may not behave as used to do in the past. So when we think about the Pasteurellas, the classical Pasteurellas, we think about the disease complex that come on the respiratory system of the pig. And I do like that slide that brings a whole perspective in terms of that complex, where you have the primary infection, and it could be bacteria or viruses. I would put most commonly viruses, and with the exception of the Mycoplasma pneumoniae. And you have 2 ways to follow that. You may have a way where the pig got infected, and a local replication of the virus or the bacteria, and the clearance. And of course, which route we're going to take, it all depends in various aspects. The immunity of the pig, is the pig treated with any antimicrobial preventively, is the pig vaccinated, and so forth. But I'm not going on that point here. What I just wanted to illustrate here is the 2 routes that can be from the clearance and recovery from the infection, or for the complication of the infection or co-infection with other pathogens, and the real problem in terms of production and the economical effects and so forth, high mortality and morbidity, and the really consequence that I would call like more a classical outbreak of a respiratory disease. And that's how we think in terms of Pasteurella coming in and opportunistically complicating the respiratory complex, and make that a little harder to control. Back to our first slides, as I mentioned, there will be around that our discussion. We starting on considering all those cases Pasteurella was isolated. And we start our discussion on that very end here. Pasteurella was isolated from that, I was going to say beautiful lung, but an interesting lung that has a non-collapsed lungs, I would call that, and severe interlobular edema. And you can even look at some hemorrhage there, but definitely non-collapsed and interlobular edema and a pretty typical or suggestive lungs of PCV2 PERS, depending where you are, PRV, and even talk about a non-infectious, depending on the side of the world you are. You can even see cases like this with mycotoxin or acute toxication of mycotoxin that too. Pasteurella is there, and the issue is again how you would interpret and deal with the Pasteurella isolated on those cases. Moving along, the middle one, and that's the pretty classical that every swine veterinarian may see that on the field or even before they got out of school. There is a typical consolidation, and I will point out later on that not every consolidation is the same. Here we see a typical that is more on the red right side, cranial and ventral consolidation with a little bit of fibrin here that can be more or less acute. And the classical, when you see that picture, at least from my perspective, we think a lot about the enzootic pneumonia, which is basically Mycoplasma pneumoniae and complicated with Pasteurella infection. And of course, I'm listing here which is more important in terms of primary pathogen or presumptive primary pathogen, right? From the previous one, you can isolate Pasteurella, but you can isolate Strep suis, you can isolate other Triporellas and so forth. The same here. That fibrin or that type of lung, if you send to bacteriology, you can isolate Triporella and other stuff. But for our specific discussion, I'm focused on the potential primary triggers here. Mycoplasma pneumonia will be the first one. Influenza can also cause that type of lesion, but even though you can see a more multifocal distribution on the lungs, but depending on the phase, depending on the time of the infection, you can see that type of lesion. Some serotype of IPP also can show that lesion. We are all accustomed to see those APP with a lot of fibrin, a lot of consolidation, hemorrhage, necrotizing lesions on the lung, but depending on the serotype and depending on the farm, you can see those lesions. I recall seeing those lesions, for example, in APP serotype 3, for example. In some cases, they are not as severe as the others. So here's that. Moving along, and there's two pictures left here on the bottom, on your left side, and we started with the bottom one, which is this one will be the more classical APP lesions, right? And that's why I mentioned before, not every consolidation is the same. The previous one, we see a little more red, bright, and here we see a lot more dark, and some regions that a little more bright, but some lesions a lot darker, which is probably necrotizing lesions and not single consolidation. And from the field perspective, if you are a veterinarian, you're kind of writing down a submission form, which is not very common, I know. But if you are help the context for the diagnostics, it's interesting to be more specific in some of the consolidation that you are seeing. That's kind of help. So I put here some of the potential primary trigger that can lead to that one. But what I want to remind is all those cases we do have Pasteurella together in the isolation from the lungs or from the pleura in that case. Okay, the last one is the one that doesn't have much of not much of consolidation, but a huge amount of fibrin covering the pleura and the thoracic cavity, and there's also effusions here on the thoracic cavity and the potential differentials, including the isolation of Pasteurella as a result of that. Okay, I'm not keeping track of the time. Am I good? Okay. Potential scenarios based on those lungs. Primary pathogen not found, so you basically found the Pasteurella isolation. Again, you can find other stuff too. In our case here, Pasteurella was found. And the reasons for that, different types of reasons for that. The ones that I listed here was you are getting the tail end of influenza infection, for example, and you are not getting the flu out of that. And you are in the tail end of influenza infection or another type of infection, and you are collecting the very end caudal lobe of the lung and not getting the bronchioles where the influenza likes to live. Or you have an animal that is there for 24 hours, pretty green, so that wouldn't be the ideal too. And you have the combination of that in terms of what type of test you have available. Do you have only, I don't know where you're working, but perhaps you have only gel-based PCR, and the sensitivity was not as more standardized commercial quantitative PCR or real-time PCR. Different reasons of that, and feel free to bring me more reasons for that. That's the three that I thought at first. Okay, another scenario would be you did find the pathogen that you were kind of wondering about, flu or any other PRRS, and then you also found the Pasteurella isolation. So, and the other scenario that you would find would be the other thought process that you would go through, that we are dealing with an outbreak. It's a farm that we are not expecting to be positive for mycoplasma, and then mycoplasma is positive, so, and then you have your results out there. Or it's a farm that are endemically infected with PRRS, myco, flu, and then you're starting playing around the CT values, and that's how things become a little more complex, and it's not as simple as we have been discussing so far. So when you are on that situation here, you are thinking, oh, where does that get isolated? Where's the Pasteurella come from? Matt showed here there's a large number, the majority of them are from lungs, but there's some of them from liver, depending on the case, pericardium and pleura. So you starting playing around with CTs and playing around with the site of isolation to determine the importance of that or not. If you're endemic pathogen, we are thinking about, oh, I'm endemic for PRRS, and I'm vaccinated, I'm using live vaccine, and I'm detecting by PCR, so I want to make sure that I'm detecting maybe a new virus that got introduced in the farm, or maybe it's a vaccine, what I'm dealing here with. That's going deeper on the scenario. The other scenario is farms that are stable for mycoplasma, for example, under vaccination protocol and antimicrobial programs that has been what they call stable for mycoplasma, and you look at the CTs and see what would be the importance or not of that in combination with where the Pasteurella come from. I thought about other scenarios, but I think it's okay for the 15-minute talk. So, okay, back to the Pasteurellas and the family of the Pasteurellas. What we have in terms of context, in terms of microbiological context, is the Pasteurella mutocida, or Pasteurellas mutocida, and a bunch of strains that are not well characterized and understood as we have, for example, for other pathogens, HPS, all under the same family, or where you have the serotypes, right? It's more consolidated in terms of knowledge, in terms of well-studied along the years, which is the same for APP. Up there, we have the serotypes for APP, and we do understand there's toxins that are involved on that, and those toxins has or play some role on the disease process, right? And we do have other outliers. We have A. suis, And we have others that are much more sporadic or not even sporadic or rare. And we see once in a while causing and being a primary pathogen. Other Actinobacillus, which is under the family of the Pasteurellas. Okay. When we start thinking about a Pasteurella that can be a primary agent and not only part of the disease complex that are with primary virus or mycoplasma in that situation. And for the youngsters, if we don't know Carlos Pijuan, I'll invite you to Google it and looking for the importance of this professor here at the University of Minnesota that's honored one of the symposium on the pre-conference on Sunday. And one of the first work with in terms of understand those roles of Pasteurellas was this one back in 1980s. And it was interesting that with the lack or the limited amount of tools that they have at that point, the direction that they gave in terms of what we are studying today, which is 30, 40 years after. So in this work here, it was growing, finishing, increasing mortality, pleuritis, pericarditis, basically what some of those pictures that I showed. And I'm pretty sure you have seen this type of cases this year or currently. And in the same work, he talks about some of the lesions that are associated with serotype at that point. So we're talking about 1987, probably 10 years or not even that. That was published the first paper on PCR. So sequencing anything, there's nothing there. They're just working with clinical, looking at the pigs, opening up pigs, and making, of course, bacterial isolation and making assumptions and conclusions out of that. And that was very interesting and amazing how they already can give directions in terms, okay, looks like we are having some strains that they call pleurotropic and some strains that are pneumotropic, which is basically strains that can go into septicemia and strains that can be secondary or opportunistic or low pathogenics, and we are getting into that. And after that, we have descriptions of those type of strains pretty much all over the world and causing pleuritis and arthritis and some of that. And there are experimental infections that associating strains of Pasteurella with septicemia as a primary agent. And it ends up in a more recent paper looking at the variability of those strains and how they categorize those strains and classify in high, low, or non-pathogenic strains. And of course, we have non-pathogenic strains, those Pasteurellas living commensally on the upper respiratory tract. And we have they classify as a high pathogenic strains, those Pasteurellas that in those pictures on your left. And it was interesting to see that the one that has on the primary differential that I put up there, APP, they have a lesion that called APP-like lesions, which is basically, I'm not going to show histo lesions here, but I'm talking about that, which is a lesion that has a specific infiltration of neutrophils and necrosis on the lungs. And more interesting is that there are strains that can cause the APP-like lesions, but are there also strains that can cause polyserositis with no specific APP lesions. Even within the septicemic Pasteurella, there are some strains more or less severe in terms of tropism. And there's the focal bronchopneumonia, which will be the secondary enzootic pneumonia, as we used to see, for example, in mycoplasma cases. Okay, we like to look at some specific genes to see if there are specific features in the Pasteurella strains that are more virulent. It's easy. on viruses, so or 5 for PRRS. We can look at epidemiology and see the track. H and N for influenza. Bacteria in general can be a little more complicated than that. Excuse me. On this paper, they look at one specific gene and the deletion of those gene in a non-pathogenic strain, the presence of that gene in a high pathogenic strain, and the deletions of the partial deletion of the gene on the low pathogenic strain. That would be beautiful. But the problem with that was that in some of those high pathogenic strains, even though the behavior is a high pathogenic strain, they don't specifically have that gene. So the gene is not consistent presence in all the virulent strains that we have seen. Another way that they looked at it was the presence of MLST typing, which is great for consistency, but for discrimination between low and high strain can be a little tough when you pull it up a bunch of isolates and look at it. So when you look at this side of the slides, a gene or 2 or 4 gene that is present on the virulent strains, but can be lacking in others. For those that work with strep suis, kind of reminds something about that too, because strep suis has some, right? And I think it's some of the characteristics of some bacteria. And when you look at the MLST, it's kind of the same, not the same, similar to other bacteria. Oh, it's pretty conservative, but can't discriminate one strain to the other. So yeah, we are not on that path. Okay, we are now looking at the whole genome sequencing, and I thought twice and put some of the data here because it's too preliminary. But we look, and I don't know how to interpret that. But we look at the isolate, we sequence that, and we are taking the same approach as we did a few years ago with strep, and then as we are doing now and learn with Pasteurella to understand the Pasteurellas. What I would say for strep and Pasteurella, we have a better definition in terms of here's the isolate from the brain or for the joints and so forth. For the Pasteurella, I don't know if it's only my perception, but I feel it's a lot of more gray area in terms of the ancillary data where we got those, because the vast majority, as Matt showed, is from the lung. Okay, I'm not gonna go through this. I just wanna show that when you are comparing whole genomes, you run those whole genomes through what we call bioinformatic pipeline. So for that reason, it's important to compare genomes that has been processed from the same pipeline, right? Doesn't work to do, for example, as we used to do for R5. Here is the sequencing, and here you put in the dendrogram, or you compare, it's a 600 base sequence. For the whole genome, taking one category from one portion of the world or lab and compare it with the other might not be as simple as a single gene. So the pipeline is important. I probably don't know what half of the words there means, but that's the message that I want. You got the sequencing and the process, then in a way filtering and annotating the genome and matching, blasting with database that are set for antimicrobial resistant, virulence factors, and so forth. So you got the message, right? When we do that, I will start with that phylogenetic tree, which is kind of a alignment tree, which is we used to look at for PRRS and others, because it's the easiest way to get started. And I would say how many? 6 strains, and there's only on this 6 strain I would say we may have 3 groups. The branch here looks like it's easy to look at. The other figure that I would like to look at are those representation of the genes, or they call core genes, which will be everything in blue, dark blue here is similar until here. And then you have some change. Ooh. And then you have some change. You have 3 strains, which are That's great. Okay. 3 strains that has that chunk, which represent those bottle 3 here. We have 2 strains that are one chunk and then skip, and the other one, which is those 2 strains here, and one that is completely different from the others, which is the 71 here, which is up there. You kind of go from the bigger picture to narrow down and trying to understand what's going on. The other thing that you will do with the pipeline that I mentioned is the presence of a potential virulence genes, the presence or not of those genes on the genome. And I mentioned one of those genes, and here we have a panel of 14 different genes, and then you put that in a table, kind of similar as we do for Strep suis or HPS, and you start digging on that table. The first part of that table is the sample ID, and you have the MLST typing, which is well conserved, and you set your interpretation in which way that strain may or may not be. For example, if you got the first one here is the very first one that is different from the others on the previous slide, is that strain that has that chunk of gene on the end here and has a different MLST type. And if you look at here, the presence of absent, right, the virulence genes that are also different in terms of pattern from the others. And you can even look at some of those genes that are associated with antimicrobial resistance. Some antimicrobial resistance genes are present on that one, which will be different from the others. When I look at that, the question that comes to my mind is that, are those antimicrobial resistance genes related with that chunk of gene that are there? And I don't know the answer for that, but I'm just trying to bring to you how the thought process for kind of interpretation of the data go when I look at those charts. And again, then we start to look at after the MLST, you look at the Pasteurella mutosa A or D, which one is that, and the serotyping of LPS, and the presence or absence of specific virulence genes. You have 3 strains, which is kind of clumps together on those, clusters together on those, on the 3, and you have 2 strains that you do have some groups here. I'm talking about 6 strains, right? That's the reason I brought only 6 strains. So if you go 20 or something, things become much more complicated. So, as I mentioned before, this is just the beginning of the process and understand those Pasteurella and understand that what they look at in 1987, pleurotrophic, pneumotrophic, we think it might be important and might be driving some of the decisions on the field. And that's it. Thank you, Leman, again, and I'm open for questions you may have.
Any questions for Dr. Vannucci? There's one there.
Thank you, Dr. Vannucci. Of course, very interesting presentation. I am wondering if you have information on what could be predisposing factors, if you see any kind of epidemiologic data that would allow this type of strains to cause disease, something related to that?
Questions related to predisposing factors. Besides the ones that will be subclinical virus infection and things like that, I haven't seen anything specific. I did see more cases in the past that are associated, for example, with certain levels of mycotoxin in the feed that not necessarily cause the acute lesions, but it's present on the feed that shouldn't be present, and more incidence of Pasteurella on those farms. Other than that, other example that comes to mind now, Mycoplasma, for example, when they are stable and for some reasons they introduce gilts from a positive source that might have, and I'm speculating around, might have a different strains of Mycoplasma, something like that, and then they pops up again and kind of go unstable for a while, and more cases of Pasteurella. Yeah.
Any other questions? Dr. Vannucci, switching gears, we're almost getting close to the end of the session, but would you like to mention about the PERS variant classification nomenclature that we have changed, or the new reporting system, or Dr. Matt Sturz?
I'll invite Matt to do that. He's the expert.
We have a
on
captive audience, so please.
Well, I don't know that I'm the expert. So, so for those of our clients that maybe are using us, you've noticed that we have switched.
slides on that?
No, I don't have a slide. You've noticed that our PERS classification has changed as far as what we're reporting out for you. We're still giving you the OR5 sequence, but we're no longer reporting the RFLP, or restriction length fragment patterns. And so we're instead transitioning to the PERS variant system. So that's a extension of the lineage and sublineage classification. So we've moved to a variant system. So if you're more interested in why we've gone that way, why we think that variant system is more powerful to tell you which strains you're dealing with, Dr. Vanderwall has a session after lunch that's discussing kind of the PERS variant classification and the benefits of that versus using RFLP to try to determine relatedness.
And you won't see on the report the anymore, right?
No, so RFLP has been removed from our reports, and so you'll just get a variant classification.